Good afternoon to everyone, and maybe good morning or good evening to everyone else who are not in Asia. But I think this is going to be a very exciting day today. Please allow me to introduce myself. My name is Dr. Sini. I'm going to be moderating our afternoon session on the topic of the PGT-A and also the Mosaic embryos that we already invited two speakers and panelists, which is Professor Yan from China and Dr. Francesca Spinella from Italy, as part of the PGT-A, as part of the Aspire webinar series. That this is the part 2 of the PGT-A topic that we put up to our series of discussions. So without further ado, I think I just want to have a little housekeeping sort of topic that I need to share, that we will be conducting this discussion in a more interactive way. I think we'll have we already have uploaded the presentation and the talk through our website, and as you already all have the reference to look at. But to you that might not have a chance to look through to the lecture and the talk, we will probably have a couple of words from both of the speakers to remind ourselves what we'll be discussing today, and we will put some questions that will trigger some discussions. But again, we will encourage to all the attendees to be able to participate by putting up questions to either the chat box or the Q&A, and we'll bring it up and try to be as interactive as we can. So again, without further ado, I would like to invite Professor Yan and Dr. Spinella to be able to highlight the lecture of the presentation that you have put up last week. This is yours, Professor Yan.
Good afternoon, everyone. So I'm Dr. Yan from Shandong University from China, and it's my honor to be here to share my experience with you about the pit form in PGT-A. Actually, as you have we have discussed in the slide in the presentation, we know that there are several different pit forms for PGT-A. The first is the small families. Second is expand carrier screening and small number of embryos and eligible out and parent mosaicism. So this is what I think is the most important 5 different areas of the pit form of PGT-A.
Yeah, I think that will be very quite extensive discussions on that issue, because obviously there's a lot of debates and a lot of development, particularly towards how to improve the strategy to select the potential issue with the selection. And Dr. Spinella, you want to share a couple words on your talk the other day?
Hi, good morning, everybody. Thank you for the kind invitation. It's a pleasure for me to be here and share this information about mosaic embryo. Actually, the topic, the talk that I show you is about the transfer of mosaic embryos. As we know, mosaic embryos are a very particular class of embryo that are composed by euploid and aneuploid cell line. And until recently, the mosaic embryo were considered not available for transfer. But now, in the last few years, now we know that the mosaic embryos, some of this have the possibility to implant and to result in healthy baby. So today, show you how which kind of mosaic embryo have much more chance to implant and result in healthy baby, because this depends not only in the composition of the number of the cell, aneuploid cell within the embryo, but also the composition on the types of aneuploid that characterize such embryos. So I will be happy to answer to all of your questions about the clinical outcome after the transfer of Mosaic embryos. Thank you.
First of all, if I may go to Professor Yan, whilst the audience is, putting their questions to the Q&A box. So if I can ask the first question, it's a rather debated topic, and apparently in Italy, the expanded carrier setting screening. So it is something that you may want to address, whether we're thinking of the Italy are thinking about introducing small panels, which only the mutation, the frequencies are above certain threshold are analyzed. Professor Yan, in your experience, which patients are recommended to have the ECS, and which type, if you may?
First of all, ECS, we know that ECS is extended panels testing for hundreds of genetic disorders with a broad range of phenotypes. So maybe for the normal people, some of them do not want to have this test or have this screening just because they think they are normal, or they are good, or they have no diseases. Even that, maybe the family is healthy, and there are no patient in a family. So if for couples who come to our center, when we want to give them artificial in vitro fertilization like this, and if we ask them to do ECS, and most of them refuse to do this. So in our center, for my experience, I will give the advice to the people who are undergoing PGT. So these people, they know that if they have a patient, if they have a baby patient, or they have a child, or is abnormal child, they know the pain. They know they will spend a lot of money and a lot of other things to cure this child. So for these patients, if I ask them to do ECS, most of them accept this, and they said, please give me this screening, and I want more screening, more than 100, 200, 300 different diseases for the screening. So for my opinion, or for my experience, for these patients, they like to do this. And sometimes in some area, like in China, in Guangdong province, they have the some blood disease, like sarcemia. They want to do screening, like thalassemia, beta thalassemia. They want to do this screening, and even they ask us to do the screening for them. So in China, I think maybe this is different types of patient, or this is the group they want to do this. So that's my experience.
Okay, can you share to us whether in China the ECS is somewhat subsidized by the government, or this is something that the patient has to pay?
You mean who will
if the patient elected to do the ECS on top of the PGT-A they're doing, would the government or the patient has to pay?
Okay. So the patient pays this for by themselves. The government won't pay for them.
Right. So it comes back again to the economical balance when you're trying to address, particularly you have your hundreds of mutation with particular diseases, monogenic diseases that you're trying to screen. But it can be very tricky when it comes down to population to population, because obviously in Asia, you can see higher probability of thalassemia, probably a lot of difference when you see CF in Caucasian, for instance. So how do you counsel them, particularly in your setting, sir?
But then do you mean if we find the mutations, how we
how do you encourage your patient? You know that the task is so much, and you probably want to address several potential that most likely will be affected in your population in China, such as thalassemia. How do you justify that to when you counsel your patients?
First, I will do some analysis for the patients who have already do this screening, and I will find the different type or the different percent of these patients who have different mutations for different disease. I have example. The patients who have deaf, they cannot hear anything, deaf. So I will encourage them to do the screening only for the gene for deaf, and the percent of the mutations who have the deaf gene mutations in China is very high. So for these patients, I will encourage them to do this. And the cost is very low. It's only about $100 for one people. So these people will accept this advice, and I will tell them some other diseases which have the high percent in the group, like DMD, like SMA. And most of them will to do this screening, but they won't do all the screening. They only want to do some of them, like I have told them the few ones.
Okay, this is more specific. Yeah. Dr. Spinella, do you want to share your experience in Italy on this topic?
Oh, actually, it's a very hot topic, because now we are thinking to offer some of this panel to our patients. But the point, the real critical point is if perform SES also to donor of gametes. So this is a very critical situation for us, because in the public center, of course, they want to offer the screening of the color screening, and particularly some HES, but with a small number and selected number of disease. But of course, we need also to arrange a situation in which the patient want to receive gametes, and in this case, we need also to understand how to manage SES for such kind of patients. So right now we are trying to organize a guideline and to understand which kind of panel can offer, and also to set a specific cutoff for the frequency of the disease. But it's still very difficult, because we need to combine the request of private and public center, and of course offer also. Yeah, this is the question, I guess. But I think that the best organization should be to, of course, to offer a small panel, but give to the patients, offer to the patients the possibility to expand eventually the screen. Of course, if the public cannot offer such kind of SES, we need to say to our patients that there are this possibility, and give the patient choice which kind of SES. I mean, I think that we need to inform our patients in the best way with the genetic counseling, of course.
So when you say it can be publicly funded, first of all, is it legal to do it in both of your countries? And secondly, if you were to offer, would you offer it to general healthy population or potentially affected couples?
Potential affected couples, of course. Often I say in the for some tests there is a government payment. So for a small, of course, a small panel. So the idea is to provide such kind of organization in Italy.
Right. Okay. We're still waiting for questions from the audience, but I'm moving on to just another point of how to counsel the patient, particularly when we, educate the patients. Of course, there is a potential false negative in cases where the patient would have a high expectation to have good results. How do you sort of rate the false negative in your both of your centers, particularly in area with damaged DNA? How do you sort of counsel the patients? I mean, in general, and then specifically in this sort of issues. Maybe we can start with Dr. Yan, Professor Yan in China.
Okay, I will not got your questions. Can you speak again?
Yeah. So the question was that we often have to be very meticulous about the counseling process, and when it related to false negativity of the test, and particularly in the area of damaged DNA. Do you have any specific ways how to educate your patients?
Okay. So it is a little difficult to answer. So before we do this test for these couples, we have already signed a document for them. And we have already told them sometimes we have maybe we have the false negative. So we told them after the pregnancy you have to do the prenatal diagnosis to confirm the result of PGT. So it is a rule, or it is rules in China. We told the patients who have under who have do the PGT-A, all of them should do prenatal diagnosis to confirm the result. So there are some percent of the patients, or the percent of the samples will got the false negative. So we will tell them most of them are real negative, or most of them, because the technique we use is good, or is good enough to do the diagnosis, and not for experiment, not for experiment. So most of them know this, and they want to this because they have no choice.
Yeah.
Yes.
Yeah, you're right. You're right. Dr. Spinella, your comments on that?
Of course, also in our case, we have informed consent, and in which we explain all the pros and cons of the test, of course, and the possibility also to incurse in such rare event. And also in Italy, after PGT, we also asked to offer, to perform prenatal diagnosis, of course, especially for such kind of patients performed this analysis. Yeah.
Right. Well, PGT-M is not an easy topic, isn't it? But
yeah.
again, we'll get to more the difficult ones. And I have one question from Dr. Mei. The question is, what should we do if whole genome sequencing cannot find the mutation genes related between parents and the affected children? All of their affected children, 2 children, have the same clinical symptoms. Can I start with Professor Yan?
Okay. So your question is that if we can't find the mutation or can't find the genetic reason for these patients, but they have some disease which can be diagnosed by the doctor, right? So how do we consult the patients? Is this your question?
Yeah, the question is they cannot find.
Okay, I know. So in the clinic work, many times we will face these situations, and most of the patients they want to get a positive result, and sometimes we have some like positive result, or sometimes it's not. It's VOS, you know, it's VOS. So it's difficult for us to give them some advice. In this time, especially in the families, they have no other children, and they want to have a healthy baby. Sometimes we will give the advice of use donor oocyte or donor sperm for them. So it is legal here in our center to do this. So this is my experience.
Yeah. Dr. Spinella, you want to make comments on that?
Oh, yes, actually, we also we also recommend to perform additional investigation like whole genome sequencing to understand if there are some additional information that we can obtain with more detailed information. Otherwise, of course, also for us, we will propose also the heterolog PGT.
Right. Well, let's talk to lighter topics, but more difficult, debatable topics, particularly in the area of Mosaicism, which we already have a question here. So Dr. Jacqueline Sudiman, who asked Dr. Spinella, what is your cutoff point for Mosaicism in PGT-A? And is it still okay to transfer the Mosaicism if it's less than 30% in case the couples do not have any euploid blastocysts?
This is a very important question. Actually, as you see in my presentation, it has been demonstrated that the potential to implant and also to result in a healthy baby depend on the level of mosaicism, on the level of the number of aneuploid cells detected in trophectoderm biopsy. And so we define also a cutoff in which we can distinguish a group with a lower potential and a group with higher potential. In our experience, this cutoff is 50%. So embryo with the high level of mosaicism, higher than 50%, have much lower chance to implant and result in healthy baby compared to groups with the lower than 50% of aneuploid cells. So of course, if I need to choose between a high level and low level of mosaicism, in a situation in which there are no euploid and more mosaic embryos, I will choose the one with the lower level of mosaicism, lower than 50%. And Among these among these groups, of course, I will choose the one that show the lowest level of mosaicism, usually 20 to 30% of mosaicism. This is our orientation, our workflow that we use to counsel our patients. Of course, we need also to know which kind of chromosome is involved in aneuploid, in chromosomal mosaicism. So it's a sort of combination of these two parameters, the level of mosaicism and the kind of mosaic embryo. Usually single monosomy or single aneuploid and segmental abnormalities have a much more chance to result in implantation and epipedy, as shown by our studies.
Just out of interest, Dr. Spinella, when you say differentiating between the high level and the low level mosaicism, would that practice be applicable when you're collecting the data of implantation of mosaic embryos? Or when we say mosaic embryo, one fits for all, mosaic is mosaic. How do you differentiate in your data collection settings?
Between what? Between mosaicism?
Yeah, the low level.
The low level and high level. Okay. Okay. In the system that we use for the classification and for the analysis, we use NGS-based PGT.
Yeah.
We can accurately detect the copy number of each chromosome.
Yeah.
And when, for example, and to do this, ESHRE recommendation that were published this year recommend to perform experimental model and validation study to perform such kind of classification, because the validation study will allow us to arrange the exact copy number that correspond to an exact percentage of mosaicism within the trophectoderm biopsy. Maybe I have some slide that I can show you about this kind of experiment that are recommended to perform. This because actually the platform used for mosaicism detection, not all of the platform can call automatically the mosaic, the chromosomal mosaicism. So it's important to define the range between within each copy number need to be called. So in the next slide, this is regarding the clinical outcome, but if you can have the next one, again, another one. Okay, here, for example, this is a plot obtained after the analysis of euploid embryo, trophectoderm with only euploid cells. And you can see in the x-axis the chromosomal position, and the y-axis the copy number, and all the small plot dot in black are the reads that we obtained after the analysis. Each reads are counted and compared with a reference, and if we have much more reads in our sample, this indicates the presence of 3 or 1 copy, so the presence of a trisomy. In this case, all the reads, all the small black points, dots are allocated close to the copy number of 2, indicating that all the chromosomes are deployed. There are two copies for each chromosome, so it's an euploid embryo. If we go in another slide, in the next slide, here, if the signal go up toward the other green line, it indicates the presence of a trisomy, because in this case we have 3 copies for chromosome, and vice versa. If we go in the next slide, we can see if we have If the slide go down, this is a monosomy, so a single copy. And the next slide, I will show you an example here. For example, this is a mosaic embryo. Actually, is in our trophectoderm biopsy. Probably we have the presence of aneuploid cell. How many aneuploid cells? Of course, we don't have the possibility to count the number of the cell within the biopsy, but in this way we can arrange the exact copy number. If we go with the next slide, I will show you that we need to define the exact range within we can call the mosaicism. And in the next slide, I will show you how. This is the experimental model in which we combine aneuploid and euploid. We can combine euploid and aneuploid cell line. In this case, aneuploid for chromosome 21. And we need to perform different dilution or different combination of euploid and aneuploid cell line to obtain a different percentage of mosaicism. In the next, and after analysis of all of these samples, I will show you in the next slide. We can obtain a sort of trophectoderma model, in which here in this slide only 2 cells are aneuploid in a combination, in a mixture of euploid cell line, and as we can see, we can detect 20% of mosaicism, because there was 2 out of 10 cells, 2 aneuploid out of 10 euploid cell line. And go ahead with the other slide, just showing that for each different combination of model, different combination of euploid and euploid cell line, we can obtain a different level of mosaicism. In the next slide, we show you an example with the you can go also very quickly because they are similar, but to show you how the different mixture can give a different level of mosaicism. And this kind of experiment will allow you to set up, to define the cutoff for each level of mosaicism. And this is an experiment performed with chromosome 21, but of course, we need also to perform this kind of analysis for other kind of aneuploids, such as monosomy, segmental. So in this case, using this kind of approach, we can not only detect mosaic accurately, but also define the level of mosaicism within the trophectoderm cells. Thank you. I'm sorry for being.
No, that's very interesting. If we can just go back to the, I think the slide 2 or slide 3, when we see the perinatal outcome, where it's about 98% of the live birth resulted from the mosaic. The one before? Yeah. Oh no, the one before. Yes, this one here.
Yeah.
This is interesting because can you explain to us then your thoughts of whether the mosaic cells were actually self-corrected, or the cells themselves were actually just disappeared? What's your thoughts on that?
Yeah, actually, there are just some hypotheses based on experimental mouse model of mosaicism. The experiment of Bolton performed on mouse mosaic embryos demonstrated that when the level of aneuploid cells within the embryo are lower than 50%, the embryo during the development may rescue this kind of aneuploid cell and become completely euploid. How? This in the experiment of Bolton, also other additional information suggests that aneuploid cells may have a reduced rate of proliferation and an increased rate of apoptotic events. This leads during the development to a reduction in the number of aneuploid and an increase in the number of euploid cell line. So the embryo after the development will be completely euploid. Of course, this is just an hypothesis, but we think that this is, could be also occurred in human embryo. From our data, as you can see in this presentation, we obtained a very encouraging result. Actually, we found that the majority of mosaic embryo implanted, and that about 30%, 30 to 40% of mosaic embryo resulted in healthy babies. Here, in this graph is represented the result showing how all our pregnancy tested with obtained after the transfer of mosaic embryo were tested with prenatal test, and all of these were normal. All of the fetus were normal. In particular, 98.6% were normal, and only 1.4% were abnormal. But this abnormality was not related with the chromosomes involved in mosaicism. So was an aneuploid that was independent of mosaic event. So our idea is that during the development, the level of aneuploid cell may be reduced during the development and then completely disappear in the fetus. But of course, we know that there are also some exceptions. For example, the paper, the case report that published Professor Vahraman in the March of this year demonstrated that in some cases the transfer of mosaic embryo may result in mosaic fetus. Actually, if I remember well, was a monosomy for chromosome 2, was a mosaic embryo with a monosomy of 35% for chromosome 2 that was again found in the amniocentesis, but was a trisomy, and then 2% of monosomy for chromosome 2, but just 2% of cells were detected in the baby. So, in a majority, in our experience, we obtained only euploid embryo. But of course, in some case, mosaicism may persist in the fetus. So we need, of course, to collect more data about this and provide much more information to be confident of our of all the different kind of situation. Different kind of mosaic embryos.
Did you differentiate between the low level and high level mosaics, mosaics in this 465 samples? Yeah.
Here we need actually here we didn't found any aneuploid. Any mosaic correlated aneuploid fetus or baby in this case, independent of which kind of mosaicism we observed.
Right. Okay. Well, the floor is still open for the attendees to raise the question through the Q&A box. I may switch over to Dr. Yan to share us your experience, particularly the mosaicism. How big is proportion of mosaic embryos do you normally obtain, and how do you manage them?
Okay, mosaic embryos is often be seen in the result in our center. Actually, with the technique NGS. Nowadays, I found that more and more mosaic embryos comes, and I have discussed with with the members in our laboratory why this happened. There are about 30 to 40% of the embryos are mosaicism. They told me sometimes it's just because the technology of the NGS they can detect more and more details of the embryo, and sometimes it's just because the quality of the biopsy samples sometimes. So actually, some of the mosaicism is not actually the mosaicism. So they told me to tell the couples who are undergoing PGT that mosaic embryos can be transferred if they do not have a normal embryos. And actually, we do this for these patients, and we found that most of them, if they got a real pregnancy, most of them can have a live birth, but the loss rate or the abortion rate of these patients is higher than those who transferred an normal embryos. And we also found that some of them have the biochemical pregnancies and they lost after biochemical pregnancies. And this encouraged us to do the follow-up of this patient who have the live birth. And we also have the follow-up of this patient, and we found them, if they have a real live birth, most of them, or we can call almost every one of them have a normal karyotype. I mean, the baby, the child have a normal karyotype. So it comes to me a question that whether the mosaicism is really a mosaicism. Maybe it's just a mistake by the technique, because we only test about 5 cells and no more than 10 cells of the blastocyst, and it's not the ICM cells. It's just T cells. So in my opinion, I encourage the patient to do the encourage of mosaicism, but there are some sequence. First of all, it's only have it's only have the mosaicism for only one chromosome, and the percent of the abnormal is low. And the second, it's the embryo who suffered from the mosaicism cannot be the big cannot be the chromosome like chromosome 21, chromosome 18, or chromosome 13. Because for this chromosome, they can have an abnormal baby, and most of others abnormal embryos will have the abortion or the miscarriage. So this is my opinion.
What's your mosaicism rate in your biopsy in your center, doctor? What's the rate of mosaicism of sample biopsy at your center?
It's about 30 to 40% maybe.
Yeah, and do you think it's related to the patient characteristic, age related, as you said, it might be something that is neglectable because of this procedure related mosaicism. What do you think?
Okay, so I do not know the reason for them, but I think maybe it depends on the different types of patients we do. For PGT-A, we only do PGT-A for the patients who have recurrent miscarriage and the patients who have recurrent implantation failure. But only some of them or a little of them are the PGT-A for the advanced maternal age, especially for the AMA patients who have already have a healthy baby. So for the AMA patients, we do not do many for them. I mean, it's maybe it's just because of the type of the patients. They have recurrent miscarriage, they have recurrent implantation failure. Maybe some of them actually have the mosaicism or have the abnormal chromosome, but we cannot find from the karyotyping. Also, maybe some of them have the chromosome by themselves from the blood we test for karyotyping, and it is different of the germ cells. I do not know whether it's this correct. It's just one opinion of me.
Sure. Dr. Spinella, you want to make comments on that?
Yeah, of course. So yeah, I have a question for Professor Yan. Your classification, you classify mosaic when only chromosomal mosaicism are present in the trifectoderm, no full aneuploid. It's correct? For you, mosaic embryo is the one with the only chromosomal mosaicism, not with the full aneuploid chromosome.
Oh, yes.
And you classify
full chromosome mosaicism. Do you mean the microdeletion or microduplication?
No. I mean, in your kind of classification, you classify embryo as a mosaic when it's composed by only mosaic chromosome, no? Or mosaic chromosome and full aneuploid chromosome. I mean, because there are two kind of mosaic embryo. One composed with only mosaicism, only mosaic embryo, only mosaic chromosome, sorry. Another kind of embryo composed with the chromosome affected by mosaicism and chromosome affected by full aneuploid.
Full aneuploid, yes.
So I think that you mean embryo with the only chromosomal mosaicism as the unique kind of aneuploidy.
Yeah.
Okay. So yes, the point is that you find much more mosaic embryo with NGS because NGS is much more sensible. I mean, the resolution I have is higher, of course, and so we can detect mosaicism from 20 to 80% of mosaicism. And if you perform such kind of validation study in which you can arrange your threshold, of course, you will reduce the possibility to obtain to see artificial artifact mosaicism. Of course, it's possible to have artifact in our trifectoderm biopsy. I agree with you, because in sometimes the quality of biopsy is very poor, so there are rumors in the result. But you can distinguish this kind of artifact of rumor from the real presence of aneuploid. So I think that using these two kind of approach, a validation study and expertise in the interpretation of the plot of the image will, of course, improve the accuracy in detection of mosaicism. So my idea is that technical artifacts are not present in using such kind of setup of our PGT analysis. So we need to perform technical validation and validation study to be sure to detect the real presence of mosaicism. And also you found you say 30 to 40% of mosaic embryos in your patients. Yeah, maybe there are very younger patients. I understand. Not because also in our study we found that the frequency of mosaic embryo are higher in younger women compared to older ones. This is a very important notion, because we need to inform and counsel our patients, because MAA have much lower possibility to have both euploid and mosaic embryo compared to younger. So maybe it's better to pay attention to younger patients in which more mosaic embryo are available, and is in this situation in which we need to, in case of no employed available for transfer, of course, we need to recommend and to select the embryos with the higher chance to implant and to result in healthy baby. So, I mean, I agree with you. We have a lot of mosaic embryo, especially in the younger women, and so we need to know the clinical outcome of each kind of embryos to perform a better counseling for our patients.
This is interesting. Obviously, you're afraid this can be related, but this can also be procedural related. Now, this can be age related, as you said, or this can also be a procedural related, or even the equipment related, which is the NGS factor. So I know that we will be talking about the non-invasive PGT-A next week, and I'm encouraging audience to also participate our PGT-A part 3 session next Saturday. But maybe Dr. Spinella can share us a little bit. What's your thoughts if we were to look at from the sample of non-invasive PGT-A in related to the mosaic levels? What do you think?
Okay, I think that non-invasive prenatal implantation genetic screening will be a very amazing, innovative approach. But of course, we need much more research. We need to understand what we can have in the stent medium, because actually we know that we obtained a very fantastic and encouraging result obtained with comparing the non-invasive PGT with the trophectoderm PGT. We found other study reported high level of concordance, 80–90% of concordance, but not, of course, 100% of concordance. This because probably in the spent medium we will have, in some cases, we can have the aneuploid cells that are released from mosaic embryo. So in this case, the situation identified in the medium is not exactly the one present in the embryo. So I think that we need to know the mechanism of mosaicism and mosaicism rescue before to apply this kind of PGT. This is my idea, because of course I think that we will find much more mosaicism in the spent medium. But once we understand the biology of mosaicism, we can interpret better the result of PGT and use this kind of approach, because of course I will encourage you to use this kind of non-invasive approach, but we need to understand better the biology of mosaicism.
Dr. Yan, just the last comment on this topic.
Okay. So I haven't got the question.
Or just in regards to non-invasive PGT-A in related to the mosaicism rate. Do you think that non-invasive technique may improve the mosaicism, or in fact it may worse the outcome?
Worse outcome.
Do you do any non-invasive PGT-A in your center?
Yeah, we do some PGT-A actually. For all the patients who are undergoing IVF, about 10% of all the patients do PGT-A. And most of them are the patients who have recurrent miscarriage or recurrent implantation failure, and not for all the advanced maternal age patients. So I think PGT-A actually we have done RCT for the patients who have a normal history, or they do not have the miscarriage history or any implantation failure history. Only the patients who want to do IVF, we do a RCT for them. Some of them do PGT-A, and some of them do only the IVF procedure. And we have drawn some conclusions, but the conclusions is still unclear. So for now, we can find that there are no difference for these patients who do IVF. This means maybe the patients, young patients, IVF patients, they do not need PGT-A for them. But sometimes maybe they have the miscarriage rate for the patients who have PGT-A procedure, and for the patients who have IVF procedure, most of them have the same rate of cumulative live birth rate. So I think.
Yeah, I think we're just about 2 minutes about to close our session, but it's been a very interesting discussion in the last 1 hour. So I'd like to conclude with several points regarding the PGT-M and also the mosaicism aspect of PGT-A. And I think we still have a lot of room for improvement, if you like, particularly from the expanded carrier screening, particularly in the populations, Asian population with thalassemia, NCF, and SMAs, and in Caucasians, and obviously this is something that we need to address as a population, based screening, and the aspect of mosaicism is obviously more challenging, particularly when we have quite a significant number of mosaic embryos found in the Dr. Yan Center, which is somewhere up to about 30%. And quite interesting that the Dr. Spinella also mentioned about the younger patient may have a higher incidence of mosaicism, which again, something that for us to continue to look for how to improve and what to expect with our mosaic embryos. And long-term follow-up, particularly with the perinatal outcomes, which have been shown before, about 98% of the mosaic embryos being transferred resulted in a normal live birth, which gives us more confidence in allowing this mosaic embryos to be transferred with very cautious of counseling process to make sure that it's not misunderstood about what to expect to be expected from these embryos. So I'd like to conclude this session by thanking Professor Yan and also Dr. Spinella and all the attendees to join our session this afternoon. And just to remind us again that we have another PGT-A session next week. That will be our part 3. And we'll be talking much more detail, particularly in the area of non-invasive PGT-A, which again will be a very exciting discussion next week. So on behalf of the Aspire, I would like to thank everyone for the time this afternoon. So hope you all stay safe and healthy, and see you next time. Thank you. Bye-bye.
Thank you.
Thank you. Bye-bye.
Thank you. Bye.